So, welcome everybody. It's Lucas here. Today's show is called Dangers of Modern Medicine. I'm joined here with Dr. Robert Pearl. He's the former CEO of the Permanente Medical Group. He was named Modern Healthcare's 50 most influential physician leaders. He serves as a clinical professor of plastic surgery at Stanford University School of Medicine, and he's on the faculty of Stanford Graduate School of Business. He's got a new book, which we'll be chatting about today, which he'll show you here if you're listening on the video, and it's called Uncaring: How the Culture of Medicine Kills Doctors and Patients. You can learn more about his book and all of his work at robertpearlmd.com. We'll link up in the show notes as well. Robert, welcome to the show.
Thanks, Lucas. It's great to be here and broadcasting around the world.
So book is a big project and you're kind of going straight up against your own industry. I'm sure you're already getting a lot of flack for this. Has this been a battle that you've been waging for many years, or is this kind of your first time starting this battle with your colleagues in your own industry?
So for 18 years, I was the CEO in Kaiser Permanente, leading over 10,000 physicians and providing care to 12 million people around the United States. So I had a lot of exposure. And when I stepped down as CEO, I wrote a book called Mistreated: Why We Think We're Getting Good Healthcare, We're Usually Wrong. And it looked at the systemic problems. And again, for your audience in Europe, it's different than the United States, but there's a lot of overlap and commonality. In the United States, there's insurance issues because we don't have universal coverage. There's issues with organization, a lot of fragmentation, doctors working alone, hospitals not being integrated with each other. There's technological concerns in the United States. Believe it or not, the most common way doctors exchange information is through the fax machine, an 1834 invention. When I tell the students at the Stanford School of Business about it, they ask me, "What's a fax machine?" And it's leaderless. There's no real structure. So I wrote that book, and as I traveled around, and I actually spent time in other continents as well, I was impressed that something else was going on. And by the way, all the profits from my first book and second book go to Doctors Without Borders. So this is really a labor of love on my part. And as I researched it, what I found, it was this physician culture, this invisible force that sometimes makes doctors heroes. We saw that in the pandemic. In the United States, there was not enough protective gear, and doctors would put on garbage bags in place of gowns and salad lids in place of masks, and they took care of patients. When the patient couldn't breathe, they passed the tube through the vocal cords, and the patient would cough, spewing virus in their face. And yet I also found a lot of problems, chronic diseases. 88% of the people hospitalized in New York City had 2 or more chronic diseases. We did a really poor job of that, some of which was systemic, some of it cultural. We saw it in some of the racial inequalities in care delivery. We saw it in the unwillingness before the pandemic to use things like telemedicine, that the pandemic saw rise as doctors were unwilling to have patients come to their office who could be contagious. And all of a sudden, the technology has been around for a long time, came into use, all the ways that we could have done better, some of which are economic, but many of which are simply cultural. The response has been interesting. First, patients love the book. They all say, this is exactly what we've been experiencing. Why could we not be getting this kind of care for all these years? And the overwhelming majority of physicians say, thank you for telling the truth. We've known it. We haven't been willing to speak about it. And then there's a smaller group who are often write in all capitals with exclamation points. How could you dare pull back that curtain? How could you let patients see our culture? How could you even imply there's something wrong with physicians? There's a psychologist, very famous one, named Kubler-Ross, and she wrote about the 5 stages of grief. How when the world changes around you, and that's what we're seeing. The 21st century is not the 20th century, but the culture's left over from the 20th century. You go through denial and anger at first, and I think that that's a lot of what the people who are unhappy about feel. I worry because the next 2 stages are bargaining and depression, but I'm hopeful they'll get ultimately to acceptance. You know, it's interesting. I actually am glad for, I'll call it, quotes, the negative reaction, because in the United States, often you don't get the interspersing of opinions. The same place saying, this is the greatest book ever, and this is terrible, because that's how conversation happens. And this is what it's all about, Lucas. How do we have a discussion? The bigger the group, the more diverse, bring people from around the world so we can evolve medicine in a positive way.
Strange question for you, but medical doctor, 3 years out of school, 20 years out of school. Do you have any evidence as a, from your work, is one better or the other? Are you like this? I've been trying to understand like the experience fallacy. Is there more experience if I'm going to, whether it's a dermatologist or an oncologist or whatever it is, should I prefer seniority if I'm making choices as a patient?
So in Uncaring, I have an entire chapter about what patients should be wondering about and the 9 questions they should ask.
Okay.
The more important thing is how much experience do they have now? And it's particularly relevant when it comes to a procedure. So if you need to have surgery done, you want to be knowing, how many of these surgeries did the doctor do last year?
Last year, right? Not
career last year. A whole lot more than 100. That's not the big difference.
Yeah.
But in the United States, as an example, the operation that women need when they have to have their uterus taken out can be done in 2 ways. It can be done through a big open incision. You spend 3 days in the hospital, 6 weeks getting better, or laparoscopically through these little 2 telescopes, and you go home the same day, and within a week or 10 days, you're back to playing tennis if that's your particular passion. The problem with the laparoscopic approach, it's harder. You're looking through these little telescopes, and it's more difficult. And you can't do it in everyone. About 80% of women, maybe 90%, could have it done that way. When I asked the chiefs of obstetrics and gynecology in Kaiser Permanente, how many of these operations would someone have to have done last year for you to let them do it? Not who would you pick? Over your minimum, they all said 3 or 4 a month, 35 to 50 a year. What if I told you that in the United States today, half of the operations are done by doctors, OBGYN physicians, who do fewer than 10 a year?
Wow.
I mean, that's where the problems happen.
Yeah.
It sometimes happens with new physicians, to the point you're making, because they haven't done enough experience.
Yeah.
Sometimes happens to ones later on because the specialties move past them. I think that's the more relevant question. How many of these did you do last year? And if they didn't do very many of them, then you probably should look for someone with more experience. You're more likely to get a good result, less likely to get a complication.
My mother spent her career in hospital administration. She worked for Kaiser for quite a long stint, actually. Wow. And she's quite positive about the healthcare system, her experience, but she always tells me and told me, never leave anyone alone in the hospital, just full stop. Don't leave anyone alone. And she just said, you just need an extra set of eyes on everything, whether it's an IV drip, whether it's a medication, just double checking. What do you think about that advice? You can criticize my mother. She'll be okay with it.
I'm sure she was a wonderful mother and raised you well, seeing your podcast, being here. No, what I would say is I in the book, I don't favor an antagonistic approach.
Yeah.
Don't view the doctors or the nurses as being the problem.
Right.
See them as being very dedicated professionals.
Yeah.
But recognize that mistakes happen.
Yeah.
You know in the United States that somewhere between 100,000 and 200,000 people die every year from medical error. We know that certain times of day, or really night, is a higher risk that's there. So I see it as really just being a supportive person who can make it easier. I mean, the challenge in hospitals today is that most patients don't spend very long. So while they're there, it's a pretty intense moment. Yeah. And having someone holding your hand that you love, who can get you the things that you need, make that experience a little bit easier. So I rather see it in the positive than in the negative.
Yeah.
I think it's nice to do that and to be with someone during that time. And I feel really bad for the patients, and there are quite a number of them who are in hospitals today who simply don't have anyone there by their side. It's a lonely, depressing experience. and one I think we have to address within the culture of medicine.
My second child was born on a Saturday night at 3 a.m. And being the neurotic person that I am, I read all the literature. I'm like, this couldn't be the worst. It's the worst time to be born. I know that. High risk pregnancy, problematic emergency C-section, all of it. And I'm sitting there, and all this stuff is happening. He flatlined twice during the birth, and I knew all this stuff going in, but I just felt like I had no agency whatsoever. I knew it on the way to the hospital in the taxi. I knew it at 11 p.m. I knew it at 1 a.m. I knew it as things were escalating. I don't know that much, but I knew enough to know that what was happening here was my emergency C-section was happening at the worst possible time with the most, no matter what their intentions were, which were completely fabulous. Everything went well. He's a super healthy kid, but people get themselves in these situations a lot. How do patients start to take back agency? How could I have better prepared myself for a situation like that? Knowing that Saturday night at 3 a.m, this is not the time when doctors are at their best. It's not the time when there's the most staff. It's not the time when anybody's making the best decisions, not because anybody's bad, but just because it is what it is. How do we deal with that? It just seems like a bad roll of the dice.
So a couple of things. I'm a plastic surgeon, but what I specialize in kids with cleft lip and cleft palate and birth defects. So I know your child's problem exceedingly well. I've often been in that delivery room ready to do an emergency procedure that's there. I think in the heat of the crisis, you can't have agency because you don't have expertise.
Just don't. Yeah.
And you're going to be a problem. Get out of the way. Let the doctors and nurses do the right job.
Right.
But where you can have agency is in advance.
Sure.
What do I mean by that? Again, in the book, I talk about how American hospitals tend to be 5-day hospitals. And on the weekend, there's just not the staff that's there. And I offer some ways that you can make it into a 7-day hospital without overburdening the staff, without increasing cost, and actually lowering expense and raising quality, because on the weekend, a patient admitted on Friday night is going to spend an extra day in the hospital. That's not good care. That's not good service. And that's higher cost that's sitting there. But what I would say when it comes to delivery is asking, how do they staff the delivery area? And some hospitals have doctors there all the time. A Saturday night looks just like Wednesday morning. They have a physician's assigned. It's not for 24 hours. It's for 8 hours or 12 hours. It's a manageable time period. He or she doesn't leave the delivery area. So there's always care that's being done. And the experience in the middle of the night should be basically as good as during the day, particularly if the hospital has a higher end pediatric service, because that's the other half of the care that's needed, both the obstetrician gynecologist and the pediatric that's there. Often what patients will say is, well, I want my OBGYN to deliver my baby. And that doesn't make any sense. How can the physician be in the office and in the living room at the same time? How can they be home? That's left over from a different era again, where I think it's how do you have a modern system in place? And the challenge for doing so actually is as much the physician culture as the systemic pieces. Although I'll add one other thing. There's a symbol, I'm sure you've seen it. It's called the Caduceus. It's these two snakes winding around the staff, the symbol of medicine. I see that one snake as being the system, one being the culture. They're intimately entwined. You can't take one apart from the other without causing a problem, maybe creating danger. And that's how I see the system and the culture. So I have to speak about both at the same time. But if we're going to evolve into a system like the one that hopefully you were in, I don't know where it was, where the child got excellent care, I think that's the piece. And agency, as I say, starts in advance. You have 9 months to prepare. Make sure the facility has the staffing that it doesn't matter whether it's Saturday night or Wednesday morning, because the human body delivers 24 hours a day, 7 days a week.
Sure. So, I mean, the reality is people like me do have time to prepare. I do have the access to the books and time and information, the luxury of all this stuff. The reality is, of the 7.5 billion people in the world, like 7 billion of them, they're just going to get through the day. And when they go to the emergency room, it's going to be whatever happens. So with that in mind, trying to create a system that's more functional than what we have right now and trying to pull the biggest lever that's out there from your perspective. Is it the medical schools? Is it the private public sector? Is it the patients? If you only had one lever to pull, is there one that you could pull that would shift things in a better direction?
Well, you have to differentiate I'll call it the more wealthy or the more industrialized countries from the other. I consulted in India, and it's a totally different situation.
Different story.
Mortality is very, very high.
Yeah.
And not because the doctors aren't good, there's just not enough of them. The hospitals are too far. And so women who would do well in the United States having a cesarean section can't get it. On the other hand, the United States, we do way too many cesarean sections. Yeah. But the outcome is not nearly as problematic as other countries sitting there. If I had to change one thing, maybe I would change something about residency. And that the residency in the United States, that's where you learn a lot of the culture. I don't think that the training is designed around modern times. I mean, I'll give you an example. What do we test medical students on and residents on? It's arcane facts that they're supposed to memorize. That's ridiculous. We all carry a cell phone. The reason we train rote memory is because in the 20th century, remember the smartphone wasn't designed until 2007. Right. You wanted to carry that information, you have to carry 50 pounds of books. It wasn't possible. How do we evolve the thinking that's there? How do we evolve both the system of care and as a result of that, the culture of care? And probably if I could make one and only one change in all of healthcare, it'd be to move from fee-for-service to capitation. Because
say that again, fee-for-service to...
Fee-for-service, which is a doctor, a hospital does a procedure, does something, creates a bill and gets paid.
Yeah.
As opposed to getting a single payment to a group of doctors and hospitals.
I see.
To care for a population of patients.
Sure.
Because in that situation,
incentives change.
Now you start to value prevention, avoidance of complication from chronic disease. You start to offer the modern technology, in healthcare, in medicine, collaboration, cooperation. You would think that it would be a high priority. It's not. That each doctor wants to be at the top of the hierarchy.
I see.
What's best for patients is a team of doctors working as one. That starts to happen in a capitated world. Again, in the United States, we undervalue primary care terribly. Other parts of the world do a better job, by the way. But the United States, we undervalue it terribly. The data says you add 10 primary care physicians to a community, you raise longevity 2.5 times adding 10 specialists. But who do we train in the United States? The specialists. We focus on crisis and intervention rather than prevention, teamwork, access, outcomes. We could do so much better. And if you look at the data, the United States lags the other 12 industrialized nations. We're last in longevity, last in childhood mortality, far last in maternal mortality. How is this possible? A nation that spends almost twice as much as every other country in the world, and yet our outcomes are poor. It's the combination of the system and the culture.
What country do you look to as at least doing better or a model to look up to?
I think there are a bunch of them that do well. And I think you have to ask the question, why do they do well? Because they do well for different reasons.
Sure.
I think places like Switzerland and Europe do well. Places like Singapore and Asia do well. You get really good outcomes in some of the Scandinavian countries, but for somewhat different reason. I think in those countries you have an entire social net that is back behind the healthcare system. So I think when we have examples, on the other hand, what you see if you look at the healthcare cost trajectory, not the absolute numbers, but the trajectory, is that the rise is about the same everywhere. So the kinds of problems in the United States are becoming problems elsewhere. And in the post-coronavirus world, that I believe that the world will still have economic issues because the people who have been hurt the most are small businesses.
Yeah.
Again, I don't know necessarily in every other country, but in the United States,
Same.
A lot of them are out of business. A lot of them can't survive. They've only gotten by because of the government stimulus.
Yeah.
They're going to have to recoup that. And that in the United States is who employs the most people. They're not employed by the Amazons and the Googles. Those are important companies, but in the totality, it's the small businesses. And I think what we're going to see is going to be this need to control cost. And what I'm fearful of, and write about in the book, is that we're going to choose to do it by rationing. And what we should be doing is transformation, changing how healthcare is structured and the culture of medicine. A few years ago, I was in a health services building in the state of Oregon, western part of the United States. And there was this sign that said quality, service, and cost across the top. The bottom said, pick any two. That's the 20th century mentality. In the 21st century, we can do better.
Yeah.
Healthcare has just got to evolve in a way to make it happen, both the system and the culture.
So rewind a little bit. You said that investing in GPs is a much better, you're going to get a much higher return than investing in specialists. Is that correct? But the problem is these specialists are earning a 10x multiple, right? And so from a financial incentive perspective, it's really hard to convince a med student to become an ER doctor or a GP. Is that correct, or am I misunderstanding that?
Well, again, each country is different. So again, you asked about the United States. In the United States, the specialists probably make about 3 times what a primary care physician makes.
But that's life-changing money. I mean, that's a big
life-changing money, and students in the United States come out with massive debt. $250,000.
Yeah.
So you're right. Under the current system, tell me about the structure. I'm going to tell you about the culture. The culture will be exactly what you say, but it doesn't have to be. Because as soon as you move to a capitated form where you do well, and the patient does well, by the way, if you can prevent the heart attack rather than unblock it, now you can redistribute that money in a very different way. And that's actually what you see in the large groups that are able to do that. You start to see different ways to use technology once you make that shift. But it's more than that. I also think, and again, right in the book, that some of the challenge for why primary care is towards the bottom is not just economic. It's also hierarchical because culture is what you believe, you value in the norms. We believe that doctors are important, high respect and esteem if they do these life-threatening reversals. We undervalue these other pieces, but I'll tell you, as a patient,
right,
I'd rather not get those problems. I see you working in a yoga gym. You help people to avoid medical problems in the first place.
Correct.
Can you help them get it better afterwards? Yeah. But can you do a much better job in advance? Absolutely. And that's what I see in healthcare as well. And so you're right. Under the current rules, we're going to keep getting the same problems. Under a new set of rules. But what is the United States going to do? What choice will it have? I worry, as I say, rationing. They're going to say, after a certain age, you can't get heart surgery and total joints. Get to the back of the line on a queue. They're going to say this drug is just too expensive to be able to be in the formulary. It works. That's not the right way to think about it. How do we diminish the cost by preventing that disease, avoiding the complications, maximizing patient safety? These are all good things, and they align with the values, with the mission of medicine. I do a lot of surgery. I've done a lot of surgery in other countries. You go to Central America, it's hot. You're working 12, 14 hours a day repairing kids with cleft lip and cleft palate. You're eating rice and beans. You're having intestinal problems. And you come back happier than you've ever been.
Sure.
We sent a physician, he volunteered, but we found a way to get him to Liberia to take care of people with Ebola. He had to have IVs going into his arm because the suit he had to wear for protection was so hot. He was sweating so much liquid out, he would have passed out. You've never seen a human being as happy as when he came back. He was back because he felt that he had done something of tremendous value. We've lost that. Despite the advances in science, despite the added dollars, we've lost something from the past. And I believe we can re-get it by restructuring both the system and the culture.
Yeah. And Robert, why doesn't somebody run on this platform? I mean, people are running the Green Party, they're running on environment, they're running on, like, why doesn't somebody run on this platform? I think people could get behind this. I mean, in your lifetime, and for sure in my lifetime, there's going to be very, very real opportunities for collagen replacement, joint longevity. Doctor-assisted longevity is going to be a really thing. Like, we need more medical stuff, not less, but we need a system that's not broken. Do you think it is realistic that somebody will run on this? Like, why isn't there's a Green Party? Why isn't there like the health party? I mean, it seems like I've never even heard anybody propose it. Am I wrong here? Is there an opportunity for somebody to take office and focus on national health?
Well, I'll offer two thoughts, I think, for your listeners and your viewers sitting in place. The first is there's a huge industry that doesn't want to see it happen. They make a ton of money. Remember, this is almost 20% of the world's largest GDP, the United States. And so
that's huge.
That's not their priority in doing so. And I'll call that the more cynical view that sits there. It's also tough to do. It's also tough. It's easier just to do more than it is to do things better. And so I'd say that it hasn't happened yet. But as I told you about the book, patients have universally loved it. Maybe I can even show it to your audience.
Please do.
There's the book right there. Anyone who wants to get on caring, with all profits go to doctors, of course. But patients have said, yes, I've known this every time I've gotten my care. I couldn't quite explain it, but I've known it, and now you've done a good job of being able to communicate that. So I think it could happen. Yeah. It's just that the opposing forces are going to be so great. It's going to require something to trigger it. Maybe it's going to be the pandemic. That's what I think has a possibility. Yeah. Not something else will come along. But if you look at the history, and again, the book has it, 1932, doctors and policy experts came together. And what did they recommend? They said healthcare has to move into a capitated, and I mean at the delivery system level, doctors and hospitals, integrated form, and nothing happened. You look at the history of the United States, I'm going to mention 4 presidents: Nixon, Clinton, Obama, and Trump. I can't think of any sentence that I can put those 4 names together that you're going to be able to say they all agree on anything, but all 4 of them wanted to move our system of medicine from volume to value. But
volume to value, sure.
We say, even this 1932 group, the recommendations they had, Franklin Roosevelt, the president at the time, was going to move them forward. The opposing forces came in, and Congress traded healthcare reform for Social Security. This is a 70, 80, 90, do the mathematics, year battle where we keep saying we want to be healthier, get better care. Costs has got to come down. And the reality is we don't do it. I'll give you one data point, which actually became the final driver of writing the book. December 2019, we're 2 months before the coronavirus comes ashore. All right? The federal government says healthcare costs, the projection they're going to make, an independent agency, it's going to go up 5 to 6% a year, every year for the next decade. Think about that. Think about that. It's 3.7 trillion today. You do the math, it's going to be 6.2 trillion. $2.5 trillion more will be spent over the next decade. And you didn't hear a single medical organization, a single association, a single anyone say, that's absurd. Can't we use that money for education? Can't we use that money for infrastructure? Can't we use that money for jobs, for training, for health, for prevention? Can't we do better than to add $2.5 more trillion in the culture of medicine? That's what it takes. And so we simply say that's the money that's there. I believe we could do a better job, and that we could move simultaneously the systemic problems and the cultural ones.
You really got me thinking. It just seems like if somebody ran that platform, the trickle down of health too. What does health not affect, from delinquency to financial viability to work? It plays into everything. I guess it's not even as long of a commitment as some of these other things. So I'm really hopeful.
You're right. I'll come up. I'll do everything I can to raise funds for you.
Okay.
Get the vote out. You run on this platform, and I'll be your biggest supporter.
Robert, really great information. I know a lot of our listeners will want to pick up your book and support what you're doing. Tell people how to find you and what you're up to for the rest of the year.
So it's the best place to go is the website, robertpearlmd.com. There's 9 options to buying the book. You don't actually buy it from me, but you can decide. You can see the price and a lot of opportunities to do so. I would encourage people, if you buy the book and read the book, I want to know your thoughts, whether you agree or disagree, whether you like it or not. I think this is the kind of discussion and debate. What I'm going to do the rest of today is be on a couple more podcasts and talk to some other audiences, and hopefully have a more diverse and broader group of individuals engaging around it. And this is my focus for the next several years of my life. Whether it leads to a political movement with Lucas at the head, or whether it just simply moves forward a evolution in the healthcare system and the physician culture. There's so much more we can do. And like you, Lucas, I believe there's nothing more valuable than your health. And you've got to do everything you can to maximize it. And we're not doing that today. It's why the book is Uncaring: How the Culture of Medicine Kills Doctors and Patients.
Robert, appreciate your time. Thanks for your work. Let's keep in touch.
My pleasure. Thank you so much, Lucas.
One of the most popular classes that I teach of everything I've ever taught are flexibility-based classes. Back in 2007, when I started teaching gravity yoga for flexibility, many of my colleagues really made jokes. They were like, Lucas, no one's going to be interested in this. No one's going to come to this class. Yoga is about a lot more than flexibility. And of course, they were right about that last part. Yoga is about a lot more than flexibility. But if you are where I was when I first started out with yoga, where sitting on the floor is so uncomfortable, where your back hurts and your knees are way lifted, if doing even the most gentle back bend makes it feel like your lumbar spine is going to explode, those are times when you need to focus on mobility training just to get yourself back to a normal level of functional flexibility. We have a gravity yoga teacher training course, and it's been going very, very well. This is one of our newer courses and is designed to help you be a yoga for flexibility teacher. Hips, hamstring, back, shoulders, really, really powerful, long, slow, deep poses. Our graduates are working online via Zoom. They're working in gyms and fitness centers, and they're helping students to work on those tricky areas so that they can move better. If you have a major imbalance in your body and you're standing or moving or running or lifting weights, whatever you're doing, if you don't correct that imbalance, the chances of that simple imbalance turning into some kind of injury get amplified as the years go on. If you'd like to learn more about our upcoming Yoga Alliance Gravity Yoga training program, go to yogateacherscollege.com and you'll see all of the information there for our next course. This week's nutritional tip is in response to a listener question from Charmin. Charmin says, Lucas, I'm 57 years old and I am suffering from sarcopenia. For those of you who don't know, that's loss of muscle mass. And I'm trying to gain strength. I am doing resistance training now with a personal trainer 3 days a week. And I'm trying to take some supplements. My trainer has recommended BCAAs. What do you think? So BCAAs are branch chain amino acids, which is really just a fancy name for 3 specific essential amino acids. Essential amino acids, there's 9 of them, and these are amino acids that you need to eat. Your body doesn't make them. They're abundant in lots of foods, animal foods and plant-based foods, all of the above. But branch chain amino acids are almost always 3 of these 9 that are correlated with muscle mass: isoleucine, valine, and leucine. The research around leucine is the most interesting. And so some people just take all 3 of these branch chain amino acids, but some people just don't bother and they just take the leucine because that's where all the research is. Here's the thing with these amino acids. The negative effects are usually gastrointestinal stuff, meaning disaster pants running to the toilet. And this can be true with any kind of supplement. But assuming that's not a problem, Charmin, I don't think there's any real risk here for, they're pretty safe, right? They're just amino acids, so they're very, very safe. The research around leucine is pretty interesting in terms of developing and holding onto muscle mass. It might be something to take a look at. In many cases, it's overkill, meaning if someone's getting adequate amounts of protein, they're often getting adequate amounts of these branched-chain amino acids as well. Now, if you're not getting adequate amounts of protein, rather than just taking those three, it might make sense to get a complete complex amino acid profile from a protein shake or higher protein foods. So totally support you if you want to take BCAAs. Just make sure it's not upsetting your stomach. And first and foremost, I would make sure to cover your bases in terms of your total protein per day. How much protein per day? We always say base is half your body weight in grams. So if you weigh 150 pounds, 75 grams per day, and that would be absolute bare minimum, probably 0.8 or even closer to 1 gram for a lot of people is going to be really helpful. Now, just eating protein is not going to make you hold on to or gain muscle. In fact, quite the opposite can happen if you're not training. But assuming you're putting your body under stress and tension in a safe and effective way, like it sounds like you are 3 times a week, adequate amounts of protein are really, really important and crucial for building, holding, developing muscle mass. Hope that's helpful. We have a question from Amanda on Instagram. Amanda says, Lucas, have you ever done Trataka meditation? And do you think it's a good practice? I tried it the other day at a meditation center and really enjoyed it. So Trataka is an old school meditation practice where you light a candle and you stare at a candle until your eyes just start dripping with tears. It's a very unusual practice. It's a pretty uncomfortable practice. You don't let your eyes blink, basically. There are lots of different ways to meditate, right? People meditate with focusing on their breath, by focusing on a sound. People meditate by focusing on the sensations in one particular part of their body. People meditate by open monitoring everything that comes through their mind. People meditate through prayer. All kinds of different ways people meditate. This Trataka one is unique in that there's this really physically uncomfortable aspect of your eyes tearing. It's interesting in that, you take control over something that's usually involuntary. So that aspect of it is interesting. I think from a experimental perspective, I think it's a fun thing to experiment with. I don't know anyone, Amanda, who does Trataka regularly. It seems like one of those novelty items that people try and never come back to, but I could be wrong. But I've met a lot of people in yoga and meditation world. I don't know anyone who uses that consistently. It seems to be something that people experiment with in the same way that you would try something just to see if you can. I feel like this is a practice that people use that way. But all things being equal, I always just recommend people do what works for them. So if mantra meditation, repeating a word over and over in your head, if that works for you, do that. If contemplative prayer works for you, do that. If, mindful, whatever works for you, I would say definitely go for that. So if Trataka is working for you, there have been some reports of people getting headaches and getting really anxious, and haven't heard of anyone actually damaging their eyes. I don't think that your body will allow you to keep your eyes open that much without just involuntarily blinking. But yeah, just something to keep in mind. Thanks for the question. Thanks for listening to The Lucas Rockwood Show. If you enjoy the podcast, I have 2 asks of you. Number 1, share the show on social media with your friends and tag me. My handle is @LucasRockwood. Number 2 is please leave a rating and review in whatever app you're listening on. And last but not least, before you go, if you'd like to be on my mailing list, every week I send out information about the podcast, behind the scenes stuff, announcements of online classes and special events. I email about once a week. You can do that at yogabody.com/sign me up. And right now we have a free breathing worksheet on that page as well. It's yogabody.com/sign me up. Thanks so much for listening, and we'll see you next week.